more to come from SynCardia in numerous ways. And with that, I would like to introduce our moderator. And first, I'd like to thank Dr. Shah, Dr. Parikh, and Dr. Arabia for taking their time today. But Dr. Shah will be moderating today, and Kira, I'll throw it over to you.
Thank you, Peter. And I certainly, on behalf of my co-presenters, Dr. Parikh and Dr. Arabia, I'd like to thank SynCardia for putting this together. Today, we're going to discuss the role of total heart replacement for thick heart cardiomyopathies. Today, we're really going to discuss the potential utility for total heart replacement for patients with advancing heart failure and either thick heart or restrictive physiology cardiomyopathies. They may include, but are not limited to, some of the images I'm showing you here. MRIs of patients with cardiac amyloidosis, apical hypertrophic cardiomyopathy, asymmetric LV septal wall hypertrophic cardiomyopathy, or Fabry's disease, which I don't have images for, idiopathic restrictive cardiomyopathies, which we've all had challenging times treating. These diseases, some of them systemic illnesses, some of them isolated cardiomyopathies, have unique challenges that sometimes make it difficult to implant an LVAD. Many of them are associated with very small LV cavities. They often involve both ventricles and have either restrictive heart failure or RV failure. They often and frequently are associated with arrhythmias, many of them malignant. Also, this population is very challenging because diagnosis is often late, and once patients start declining, it's a rather rapid descent. We've tried as a field and a community to try to treat patients with VADs who have restrictive physiology or smaller LV cavities. These are data from the Mayo Clinic accumulated over several years, where they published and shared their experience of implanting continuous flow LVADs in patients with restrictive heart disease, many of them hypertrophic or amyloid patients. As you can see here, the survival was 0% in patients who received LVAD and had an LV end diastolic diameter of less than 4.6 centimeters. With introduction of continuous flow devices, survival on the heart transplant list has improved for patients who have non-ischemic or ischemic dilated cardiomyopathies. The data from waitlist and UNOS data was published by the Utah group here only in the last year or two. And what they found is patients with thick hearts or hypertrophic cardiomyopathies still had poorer survivals and exhibited no improvement in recent years like the other types of heart disease. So this remains a population that is difficult to treat with traditional MCS devices, that presents clinically very ill and can rapidly decline with very few tools at our hands. So with that being said, I'm going to hand the presentation over to Dr. Parikh from Mount Sinai Hospital to discuss his case.
For that introduction, and SynCardia for inviting us to share our experience and the case with the community. So let me just expand this here. So today I wanted to present to you a patient of ours who is a 47-year-old gentleman with a history of idiopathic restrictive cardiomyopathy, who presented in acute decompensated heart failure with progressive class 4 symptoms. He had ascites and anasarca essentially one day after he returned back from his trip from Bangladesh. He had a past medical history that comprised of non-ischemic cardiomyopathy that was diagnosed in 2011, poorly controlled diabetes with a hemoglobin A1C of 10.2, atrial fibrillation, as well as chronic kidney disease. His last follow-up in the United States with a cardiologist was in December of 2018. At the time, he displayed NYHA class 3 symptoms, and as evaluation for his cardiomyopathy, had right heart catheterization done that showed elevated filling pressures and a low cardiac output. As you can see here, his RA was 25, PA was 38 over 25 with a mean of 29, and a pulmonary capillary wedge pressure of 22 with P waves to 35. There is somewhat of an equalization of the diastolic pressure gradients there, suggesting a restricted phenomenon. And he had a cardiac MRI performed to better understand the etiology of that. 35% of the normal left ventricular size was not dilated. And there was no evidence of fibrosis or infiltrated cardiomyopathy on that MRI. In the interim, since his last presentation, he had multiple admissions or hospitalizations in Bangladesh for decompensated heart failure until he decided to move back to the US and seek medical care. And he essentially came from the airport to our hospital. When we met him, he appeared quite frail, very malnourished, cachectic. He was only 5'1" in height and weighed about 130 pounds, but grossly anosarchic. He has decreased breath sounds. He was tachycardic, and his abdomen was distended with ascites that was present on exam. As I mentioned, he was lukewarm. He had tubeless edema and anasarca with edema all the way up to his mid-back. And laboratory evaluation also suggested how chronically debilitated he had become. He was hyponatremic to 125. He had evidence of end organ dysfunction with a creatinine of 1.86. He was severely hypoalbuminic with albumin of 1.8 and a pre-albumin of only 17.7. Here you see his chest x-ray with bilateral pleural effusions as well. So he was initiated on milrinone, and here is his echocardiogram. His parasternal long axis view, his LV dimensions, at least end diastolic dimension, was only about 4.7 centimeters, so not dilated as one would expect in end stage of a non-ischemic dilated cardiomyopathy. And on the right is your apical four-chamber view, shows severely depressed EF, but again, remarkably not really dilated left ventricle. And his RV, although squeezing, it's moderately dysfunctional as well with biatrial enlargement. The official read of the echocardiogram showed an EF of around 20%. His LV diastolic dimension was around 4.7 centimeters. Mild to moderate RV dysfunction by echocardiogram, biatrial enlargement. He also had mild to moderate MR as well as moderate to severe TR, which is not displayed here on the screen. We proceeded to perform a right heart catheterization, and on milrinone of 0.375, again, he has severely elevated filling pressure that you can see here, RA of 25, PA of 44 over 25 with a mean of 31, and a wedge of 25. Again, sort of like your diastolic equalization with a low cardiac index of 1.6. Hemodynamically, the RV was again struggling. He had a CVP to wedge pressure of 1 and a PAPI of only 0.76. At that time, we proceeded to escalate inotropic support for him, and in hopes to sort of support him better, we placed an intra-aortic balloon pump. Given his left ventricular and diastolic dimension and cavity size, an Impella or other temporary mechanical support devices, we contemplated about, but felt that we may struggle with that with shutdown or ventricular arrhythmias. He was already having ectopy, so we proceeded with intra-aortic balloon pump. With escalation of diuresis with furosemide infusion, aquaphoresis of CHF solution, which is essentially just ultrafiltration, and eventually requiring CABH for progressive renal dysfunction. Despite all these measures, he remained in, per time, the 50cc one was still not approved for for an indication for an adult yet. And so we proceeded with placement of the SynCardia 70cc TH on February 4th of this year as an Intermax 1 in order to support him, provide him with biventricular support and give him time to reverse his profound cardiac cachexia that he had developed. As one can imagine, the initial portion of the TH procedure was relatively routine. We were very fortunate to work with Dr. Ani Anwu, who's a phenomenal surgeon who's done many of the TH device implants before. However, towards the end of the case, during chest closure, we did run into some difficulty due to the small size of the chest cavity. When he attempted to close the chest, there was compression of the pulmonary veins leading to issues with flows. But his ingenuity and his creativeness, he used sutures to essentially suture the cannula and the ventricle to the chest cavity, relieving the pressures that he was placing on the IVC and the pulmonary vasculature. And he was able to, after trial and error, to close the chest with good outcome and good flows. He, as one can imagine, he's run into a few bumps. He developed respiratory failure and has required tracheostomy. He's in renal failure. He's currently requiring renal replacement therapy, and has bouts of sepsis with a candidemia that has since cleared with antifungals, and recurrent episodes of Klebsiella pneumonia bacteremia, which he's treated for antibiotics. We're focusing on essentially supporting him through this and address his nutritional status, getting him physically ready for an eventual transplantation, reverse this profound cachexia that he had developed over a period of several months, if not years. And he's currently listed at our institution for a combined heart kidney transplant.
Aditya, thank you very much for that presentation. Would anyone like to comment on that when you're seeing, especially a patient that's 5'1"?
Sure, I can make some comments. We have put total artificial heart at 70 cc's in 12-year-old kids who are not even 5 feet because the heart is big. And T10 was about 9 in that patient, 8.5 to 9. So I know we talk about T10 being 10, but there are other things that go into this. The size of the heart is important. If they have a large heart, even though it's a small person, you probably can put a total artificial heart by rotating it to the left side. In this patient who had a kind of a normal size heart, you can expect that you might have some feeding problems or issues. You know, the company offers the virtual surgery with feeding of the heart, which we review several of those a month from all over the world, in making sure that either the 50 cc or the 70 cc is going to fit, and that is available.
Dr. Shah, Dr. Parikh, Dr. Arabia, thank you. Thanks everybody for joining, and look for the next invite on TAH here in the weeks ahead. Have a great weekend. Stay well, everyone. Thank you.
Thank you for
Thank you very much.